Hello, everybody. This is Mark Lynn with Healthcare Business Specialists in Chattanooga, Tennessee. We'd like to welcome you again this afternoon for another session of the beginning RHC billing, sponsored by Azalea Health and ChartSpan. And this is the second of four. We added another day. So next week, I think it's January 28th on Tuesday, we'll have another session of this as well, because we are running way behind on our schedule. We'll go through this introduction stuff since you saw it all yesterday. That's me. That's how to get a hold of me. That's Danny. Danny's on the line. She'll be doing the polls today. We have some more pre-test questions, but today we're trying to make it go a little faster. We've inserted them throughout the presentation, so we can cover that material as we have the test there. So Danny, when we open the first poll, start on number 13, and then we'll work our way through 18. We'll have 6 poll questions today, so stay with us. Louise Burkhead is here with us from Trinity Medical Clinic, and she will be there to input and help us with all the questions that you guys have. She did a fantastic job yesterday. And then Kami Jones will be here tomorrow for sure. She may be with us with Louise as well on Tuesday if it all works out. There's our seminar dates for this year. Azalea and ChartSpan are back on board, so those will be free. You'll know more about those when we get closer. That's what our schedule will look like. It'll be something very similar. Here's what we do. You guys know that from yesterday, and you can find this tiny URL that has a listing of all of our services. We do prepare a lot of cost reports, so it's basically cost report season. Here is the Google, the Facebook group that we have. It's a great group there. Like I said, we're running very close to 1,000 members. A lot of really good information that people post on there. Not just me, but a lot of the other consultants are very good about posting and answering questions. Louise is very good about that. Kami's very good. Patty Harper is excellent about that. Danny Gilbert even answers a few of those as well. So next week, just so you know, there is going to be another webinar on the 29th from the National Association of Rural Health Clinics Technical Assistants. Nathan is going to tell you guys about some of the changes, and hopefully he'll tell us that the RHC Modernization Act with a $115 rate for RHCs has passed. It hasn't yet, but cross our fingers and hope that Congress does something on that. And then we will have another webinar on cost reporting next week, mainly for our clients, for letting them know what type of information that you need to pull so that we can file your cost report timely and accurately. If you're not one of our clients, information is still valuable, because if you use somebody else, if you use Julie Quinn or David James or whoever, we all ask for basically the same information, because you have to gather that same type of information to prepare your cost reports. So questions, you can type them in on the side over here. We will hopefully have 45 minutes at the end of the webinar to answer questions. We'll go as long as we can until we run out of time, like we did yesterday. So disclaimer, everything was current as of yesterday. The session is being recorded. Yes, I hit the record button. It's being recorded, and we will post this to our YouTube channel. We will post it to our website so that you can have access to it if you can't watch it today. This is where we left off yesterday. Rural health clinics can be 2 different types. It can be independent or provider-based. An independent RHC is typically owned by a physician, nurse practitioners, PAs, and the reimbursement is capped from Medicare at $86.31. Medicare basically pays 80% of that number. It's based on a cost per visit that is computed in this form 222. That's what we do, about 170 of those every year. If you're provider-based, that means you are owned by a hospital. If you're a hospital that is less than 50 beds, and what I mean by 50 beds, I mean 50 50 available beds. The available beds means how many beds that you can set up and staff in 24 hours. It's not your licensed beds. So keep that in mind. A lot of hospitals have that 49 49 beds so that they can take advantage of this. Plus, there's other programs out there for hospitals that are 49 beds or less. So those will be your provider-based RHCs. Some hospitals that are larger than 50 beds own RHCs, and those will be independent RHCs in most cases. I think there's a few older ones that slip through the cracks that are provider-based but are capped at the 8631. But if you try to become a new, if you're a hospital and you set up an RHC and you have more than 50 available bed days, then you will be you'll be an independent RHC. What are the differences in RHCs compared to normal reimbursement, what I call fee for service? Number one, they are paid on a cost per visit basis. That's why you have to do the UBO4. And I'm not sure where we're getting the feedback, but check your phone lines, everybody. I know Danny and Louise have their lines muted, but check your lines and see if they're muted, because I'm not sure where we're getting the feedback from. So they also file Medicare cost reports, and also Medicaid is based upon. Hey, Danny, can you go through there and see if there's a line open in any of the attendees?
I've looked there. I can't see one that's open.
That's weird. I was wondering why we're getting that feedback. But okay. So would they file Medicare cost reports? Also, Medicaid is based upon a cost report. Every state is a little bit different for that. So your Medicaid reimbursement rates are a little bit different. Your Medicare rates are different as well as a rural health clinic. The cost per visit is supposed to be all inclusive. However, it is not. There's things that you can bill in addition to that from a Medicare standpoint, your lab services, your technical components, and your hospital services. Those are all things that aren't covered under the RHC benefit. And here's a nice summary slide that sort of gives you an idea of how you need to bill. For an independent RHC, you're going to bill your encounters. An RHC, you're going to bill those on a Medicare Part A on a UBO4. Same thing if you're provider based. You're going to bill basically the same way on your RHC encounters. Going to use a UBO4. You're going to use a bill type 0711 for most claims, and that's going to be pretty easy. For your lab work as an independent RHC, you're going to bill that on a 1500 form, just like you did before you were a rural health clinic. That includes all lab tests. That includes even the 6 required lab tests for you to be an RHC. They're not covered under the RHC benefit, and you're going to bill those on the 1500. If you're provider based, your lab work is going to go on the hospital outpatient MPI number that you can use a UBO4 form to bill that, and Medicare will pay you fee for service. You're going to use a bill type 141 or a 131 if you're a PPS hospital. If you're a CAI, critical access hospital, you're going to use a bill type 851, and Medicare will pay basis for your lab work. And your technical components are not covered under the RHC benefit as well. So as an independent RHC, you're going to bill those on the 1500 form. And as a provider-based entity, your technical components, again, will be billed on the parent entity using the parent outpatient MPI number. Your type of bill for a technical component is going to be a 131. And for a CAI, if you're cost-based, again, you're going to be an 851 as well. Okay, charges. We talked a little bit about this yesterday. All charges must be charged the same amount for services, though the RHC collects different amounts for that. So you want to have the same charge structure. Remember, in Medicaid, there's some states that require a T1015 code, and if you use that T1015 code, then you the feedback is annoying me to no end. Okay, sorry. If you have that T1015 code, then you may have to charge what your actual rate is. So just keep that in mind. Look at what your state requires. I know some states say if you charge whatever your charges are, you put those in, and then the T1015 code is designed to pay you your Medicaid rate, whether whether you charge less than the Medicaid rate or you charge more than the Medicaid rate. But just check with your local Medicaid agency, see how they want it done, and then bill that way. So Danny, let's open up our first question here. Our first poll: charges may be established based upon A, as a percentage of the Medicare fee schedule, B, based upon your knowledge of the local community, C, you can purchase a fee analyzer for your local area, or D, all of the above. And let's see here. Danny, do we have the poll open?
Yes, sir, it's open.
Okay. Oh, okay. There we go. There we go. Now I can see it. I didn't have my little thing clicked on. Okay. And 52% of you guys have voted. We'll give you a few more minutes to vote. And 68%, 70, come on, you can do it. 73% have voted. Okay, and it is, all right, Danny, let's close out that poll there and you give me the results.
Yep, you had 48% said a percentage of the Medicare fee schedule, and then 48% said all of the above.
Okay, and the question was very ambiguous, and all the answers were right. I mean, you can use all, I mean, the question is, charges may be established based upon, well, they can be based upon anything. We recommend using a percentage of the Medicare fee schedule, typically 150 to 200% of the Medicare fee schedule. So if it says for a 99213, Medicare is going to pay you $70, then your 99213, if you did 200%, would be about $140. If you do 150%, then it'll be a little bit over $100 for that. And that's what most people, most in rural areas, use based upon knowledge of the community. They set it at 150% of fee schedule there. So those are all excellent answers there. You can use all the above, or I like the percentage of Medicare. That's the very sort of objective way to do that, to set your charges. So very good. Louise, how do you guys set your charges? Do y'all, do you have any recommendations on that?
We've always done 150, and then if a commercial insurance actually pays the full amount, we will increase at that time and document what date we increased.
Okay, that's a Louise, and that's why we have you here. That's an excellent point. Is if Blue Cross and Blue Shield of Tennessee is paying you $110 for or they're paying you, you're charging $105 for a 99213, and they're paying the $105. That means you need to increase your charges. They may pay you more than that $105. And so every January, you really do need to update your charge master. There's new HCPCS codes, there's new ICD-10 changes. A lot of times your pricing constraints from your commercial insurance companies, they may only allow a 3% increase every year. So what you want to do is every year, if you don't increase your charges that 1 year, you're going to lose that increase forever. So you want to, every January 1, look at your contracts, see if there's any such type of restrictions on increasing your charges, and then try to increase those, because it's a whole lot easier to increase a little bit every year than it is not to do anything for 5 or 10 years and then go from $40 a visit or $40 for a 99213 to $105 for a 99213. That's a little bit painful there. So you want to, this is that time of year too where your homework is to go back. If you haven't changed your charge master yet, it's still January, so it's time to go in there and do that. RHCs were really considered to be the original bundled payment. You only get, right now you get, if you're an independent RHC, you're at the maximum rate, you're going to get $69 for every visit from Medicare. The weird thing is when you look at a 99212 all the way through a 99215, Medicare pays you exactly the same amount no matter what you do. So let's go in here and we have another question for you, just to see how you get this bundled payment concept down. Patient has an E&M visit, E&M service, and also receives a trigger point injection during the same visit. A, the trigger point injection and administration is billed to Medicare Part B fee for service, or B, the trigger point injection administration is billed as an E&M service to the RHC. I've got to go back and fix the answers on that one. But the trigger point injection administration is billed incident to as an RHC to Medicare Part A. I was trying to shorten my answers to fit this, to fit GoToWebinar. Okay, you guys are answering pretty quickly, and the answers are coming in what I was afraid of. A lot of people want to do this. A lot of people. And okay, let's stop it right there because that's a good number, Danny. We close the poll out and give me the answers. Danny, will you give me the answers on that one?
Sorry, I was talking, but I was muted.
Okay.
75% said they are billed on a UBO4 incident to the E&M code.
And then 25% say you bill in Medicare Part B. That is definitely the wrong answer. That is, do not pass go, do not collect $200, go straight to jail sort of thing. So you can't bill those to Medicare Part B fee for service for that, even though you want to. You see that there's a lot of money. You see those trigger point injections, you get paid $90, $100, $110, $120 from Medicare Part B. It seems crazy that you're doing that for $69.05, but that's the way Rural Health Clinic works. It gives and it takes away, and it certainly takes away on these trigger point injections. Louise, you got some knowledge to provide for us on this one?
I do. If they're having Medicare claims rejected on that, it may be one or two things. We found out that we have to use the revenue code 0636, the injection code for the revenue code on it. And then also with Palmetto, they had some kind of trigger that was automatically denying it, and you were the one that helped me, and they had to go in and remove that trigger that was causing that automatic rejection in RHCs.
Yeah.
And since mine are starting to get paid.
Okay, good. Yeah, there's an edit. Sometimes Palmetto has weird edits in there, and if you will, let me know. We've got some good contacts. There's a guy used to be a guy by the name of Mike Barlow who was over the entire Palmetto contract, and he happened to send me some information that he really shouldn't have by accident. And ever since then, he was really nice to me, and he would do just, and I could get a lot of things done. But Mike has left, so I don't really have as good a contact as I used to have. But yeah, we'll be glad to help you. If Medicare is doing some weird edits for you, let us know, and we'll try to. And if we know, oh no, they shouldn't be editing it this way, we will try to get a hold of them and try to help you on that. But that's an excellent point. Also, what you can do if you do a lot of trigger point injections or a lot of things where there's high dollar sort of procedures, you can set up something called non-rural health clinic time. If you're an independent RHC, that would probably make a lot of sense to do that. If you're provider based, probably not as much because your rate for Medicare will be so high. We'll talk about how to set up a non-RHC hours as we go through a presentation there. But 25% of you guys really need to look at what you're doing. If you're doing that, if you really are billing those to Medicare Part B fee for service, they will pay, but they shouldn't pay. So keep that in mind. I know a lot of times we always think, oh, we sent it, it paid, it must be right. Not necessarily true. Okay, here are your payment caps here for an independent RHC. It's $86.31. Again, Medicare will pay 80% of that, so you'll get $69.05. Medicare will actually take away 2% from you as well. That's something called sequestration. It's been around for the last 10 years or so and doesn't seem to be going away anytime soon. So you technically don't really get even 80% of the cap, the $86.31. And when I say the cap for independent RHCs, if your cost per visit is less than $86.31, you will get paid less than $86.31. Danny and I prepare about 170 cost reports every year. Last year, we might have had 3 RHCs that didn't hit. that 8631. So I always say, we always use that as our numbers, 8631. If you're provider based, you should be averaging about $207 a visit. Medicare is going to pay you 80% of that. So you should be getting $166 per visit. Plus, you guys are going to be collecting 20% of what you charge. So on average, an independent RHC for a 99213 should be collecting about $94 per encounter if you charge $125 for that. You get 20% of 125 and you get the $69 from Medicare. While if you're provider based, you're going to get 80% of 207, so you'll get $166 and you'll collect $25 from the patient. Notice you're going to get $191 even though you charge $125. There's no lesser cost of charges in rural health clinics. So you can actually collect more money than what you charge. The fun part is when that's sorry old Mark Lynn, a grumpy old thing, gets his Medicare summary notice and rushes down there and says, you guys are the biggest crooks in the world because you charge 125, Medicare paid 166, and you still want $25 from me. That's always a fun one to try to explain to them. Louise, does that happen to you guys? Do you have where the patient where you guys get more money than you charge and the patient is upset about it? Is there any sort of secret to calming those people down?
We don't. We're independent based, and so we get the flat rate.
Yeah. So you don't.
Yeah.
So your charges are more than your typical charges for 992 and 3 are more than that. So okay.
Right. The co-payment is 20% of our charge.
Yeah, so okay, well that's good. It's usually the provider-based people that have to deal with that, and it's not a whole lot of. It's really hard to explain that to a 70-year-old patient why you charge 125 and you collected 166 and you still want $25. My mom, she used to all the time. Dr. Davis she went to a rural health clinic and she never understood that. And I kept trying to explain to her, so I couldn't even get my mom to understand it for years and years. So rural health clinic too, you got to remember they're strange new rules, especially for you guys that are brand new. You have to bill on a UBO 4. There are no limiting charges, so you can collect the full 20%. What we just talked about, you can collect more than you charge, no problem there. Your remittance devices are very, very strange. So how you record contractual adjustments, and we will talk about how to do that for negative reimbursement as we go through here. We have a question for that. And then you need a really good partner. Like that's why we like Azalea, because the computer systems on the back end really have to be able to send claims to Part A and to Part B, and it's called split billing. So you have to have a good system that will split bill and can handle it seamlessly behind the scenes so that your poor little receptionists or your billers are not trying to figure out where things go. You just enter it in the computer and the computer knows and sends it to the right place. And then Medicaid billing, all the stuff we tell you about Medicare billing doesn't really apply to Medicaid. So a lot of times we have pediatricians or pediatrician staff that say, Mark, should we come to your billing seminar? I'm like, nope, because we're going to talk about Medicare. The seminar we had in Clanton, we had a Medicaid representative there, and she explained how to bill in Alabama for Medicaid services. And then this negative reimbursement, we've talked a little bit about that already. That's a real pain for RHCs. And then, of course, your HCPCS. You have to include HCPCS codes in your UBO 4 claims now. Before April 1st, 2016, you did not have to. And then effective October 1st, 2016, you guys now have to add a CG modifier to pretty much every single claim that you send to Medicare. There's a couple of exceptions that we talked about yesterday. Okay, some of the things that when you're a rural clinic, some of the things that stay the same. The Medicare deductible, the $198 deductible is the same. So in January, you will try to collect that $198 deductible from your patients. You'll continue coding typically, and this may have changed last year. It's coming up changing soon. I know they're changing all the E&M guidelines as far as coding coming up pretty soon. Used to, you had a choice between using the 95 or the 97 guidelines. Most rural health clinics use the 95 guidelines because it was a little bit more attractive. to them. Louise, do you know anything about the changing of the coding guidelines? Is that something that's happened, or is it going to happen?
I'm understanding that it's on the schedule for 2021. Now, Gary Lucas covered that very good in his class.
Okay, so we're good. Oh, that reminds me too, what Gary, about those classes that we talked about, the difference between the ARCH coding certificate and the NARHC certified rural health clinic professional. I told you wrong yesterday. Susan Campbell, who's on the board, emailed me last night and said, Mark, you don't have to go every year to an RHC conference. You have to go, it's every 2 years. So I apologize for that. When I sent out my email with the slides, I put the information on that. So I apologize to the NRHC for getting that wrong, which is made me happy, but that means that I'll have to go to one every 2 years, which the meetings are really good. Like I said, I've been to every single one for 30 years in a row until kids became more important than kids and grandkids became more important than going to the meeting. Preventive services are the same. So those 17 different preventive services that you can get for no copay or no deductible, you guys can do all those. So that is one way to make some money as a rural health clinic. RHC services, you can break them down in basically 4 categories. One, and here's our Medicare umbrella. Under Medicare umbrella, where it's nice and there's no rain, is face-to-face encounters. That's where you have a face-to-face encounter between a physician, nurse practitioner, and PA, where a medically necessary service is provided within the scope of practice for that provider. That's when you get your AIR, your all-inclusive rate. That's the good stuff. That's what you want. Incident 2 is services that were provided incident to a face-to-face encounter. You charge for them, but Medicare, my Tennessee accent says you ain't getting paid. So that's what happened. That's called incident 2. You want to include those because there is a form of payment that you do get. The co-pays will increase, so you will collect additional money from your if there's a crossover, the Medicare secondary claim, if the patient has somebody, if they have Blue Cross or Humana or somebody's a secondary insurance, then you're going to get paid additional money for that. So you want to include those incident 2 charges for that. Then under the Medicare umbrella, there's things called non-RHC services. We told you what those are already: laboratory, technical components, and hospital services. So it's covered by Medicare, but not the RHC benefit. And then finally, here's your Medicare non-covered services. These are things you would give an ABN to the patient. If they want that B12 shot that we talked about yesterday, if they're doing cosmetic surgery, if they're doing some type of luxury type of thing that Medicare would not cover, then you'd give them an ABN and you would collect directly from them. A physical is still not covered by Medicare. So if you did the traditional 99387 physical, is not covered. Now there's certain things that look like a physical. There's what we talked about yesterday, those G0438s and 437s and G0402s out there, but those technically really aren't a full-blown physical. Here's how I use in my brain to sort of figure out what goes where as far as split billing. If you use your brain, that's a professional service, and that's going to go to Medicare Part A, and that's going to be a rural health clinic payable service. If you use equipment, like you use, here's an EKG machine, it's going to be a technical component. If you use some type of lab equipment to run a test, that's equipment. You can bill that. That's going to be billable to Medicare Part B. It's not going to be covered under the RHC benefit. If you go to the hospital, just think about the hospital as one big healing machine over there. That's not going to be an RHC service, and those are going to be billed to Medicare Part B. You're going to get paid fee for service for those. Unless you're a CA, then you're going to get paid cost-based for those. So that's how I use them. That's a good, simple way for me to differentiate between those. So what is an RHC visit? The definition stayed the same forever since the program got off the ground on March the 1st, 1978, and all the way through 2015, it was a face-to-face encounter, medically necessary. Have to have a physician, nurse practitioner, or PA Finally, we broke free of the face-to-face encounter regulation, and we added chronic care management in 2016 that no longer requires a face-to-face encounter. And then on April the 1st, they had something called the QVL, the qualified visit list, that you had to have, that you have to be on the QVL. That went through 9/30/2016. And then 2016, there's no more QVL. You just have to add the CG modifier to everything. So that's sort of the history of that. And then here are your eligible providers. These are the people where you can get an all-inclusive rate. Your physician, your MDs, your DOs, your dentist, your podiatrist, your optometrist, those you can get an all-inclusive rate for those. Your nurse practitioners, your PAs, your certified nurse midwives. If you're in the Southeast where I'm from, you're not going to have any of this. A visiting nurse can go out and visit the homebound and get an RHC visit. There's only about maybe 1,000 or 2,000 of those visits in the whole country. They're in like Montana or someplace like that. It's very sort of rural, and the home health agencies will not let them do that in those particular areas because there's nobody there. In most places, you have to have the home health agencies write a letter saying we can't cover these patients, and you're not going to get that in the places where we mostly go. So again, only about 2,000 visits in the whole country on that. Clinical psychologist and clinical social worker, those are eligible to get an all-inclusive rate. So if you want to add mental health services, that is a great thing to do. You can actually get paid the all-inclusive rate for them. So here is the definition of a visit here. I just copied this straight from chapter 13. I won't read it for you, but it's from the brand new chapter 13. It was just updated a couple of days ago. Okay, and then here's the old. This is the old Riverbend. I'm old enough to. Riverbend lost the contract in I think 2009, and it was around then. But here was their definition was really. It's a face-to-face encounter with a physician, nurse practitioner, PA nurse practitioner, certified nurse midwife, clinical psychologist, or a clinical social worker. So you have to have that. It must be medically necessary. You have to reach the level of a 99212, and then it has to be appropriate for the person trying. And what that means is that if the visit, I can't talk over the stupid whatever that sound is. So if it's like if your doctor always gives flu shots, that would be the example. Is there's no reason, there's no other E&M for that. Just the doctor says, and I've had a lot of doctors that'll say this, hey, I'm just going to give the flu shots to everybody, and that's going to count as an encounter because I have a face-to-face, right? No, that doesn't count. That's sort of fraud and abuse there. So keep that in mind. That's the, and then here's some of the services that are covered under Medicare Part B, but not the RHC. Dietitians and nutritionalists. You can bill those incident to nurse-only visits, injections, dressing cards, dressing changes. All those are incident to items. So keep that in mind. And then again, the definition of an RHC encounter is very limited. Basically, nurses, physical therapists, dietitians, and nutritionalists are not included in this. So here we go. We're going to have this one here is going to listen. Danny, if you open up this question here, this may be something that the people didn't know. Dietitian and nutritionalist time counts toward the 20 minutes of chronic care management time each month. And let's see here. Everybody vote on this one here, because this one will really help you guys if you are really super smart here, I can tell. So, okay, we'll give it a few more seconds for everybody to vote on this one. And Danny, you want to close the poll and give me what your answer is?
70% said true and 30% said false.
Yeah, and the 70% are right. I'm surprised that 70% of you knew that, because that's something that not a lot of people know. And this is great for you guys that I know I got a phone call from a dietitian the other day who just got a job at a rural health clinic, and then she found out she couldn't charge a visit. And I was like, well, you can count that 20 minutes towards chronic care management. So you can count, basically you'll get $67 for 20 minutes of time. So it's not the end of the world. If you can get, two of these each hour, then that's not a bad thing. So the answer to that one is true. So if you guys have dietitians or nutritionalists and you want to get a chronic care management program going, there may be a way to get those involved in your management program and really help your diabetic patients and some of the people with some chronic diseases there. So keep that in mind. Again, a 99211 nurse only visit. Do not bill that to Medicare. That is going to be you can have 99211 visits in rural health clinics. You can bill those to commercial insurance, but do not be billing those to Medicare as well. So keep that in mind, and then check your Medicaid regulations too on whether you can do a 99211 or not. I've actually seen in Alabama they used to have a code of 99211 SE that was a rural health clinic visit. So double check your Medicaid to see how they use 99211s, and we have to be very close, watch our cost reports too, because normally we would not count a 99211 as a visit, but in Alabama you would, because they got the AIR for that. So here I just copied and pasted where you can have an RHC visit. From that, I'm going to let you guys read that as we go at a later time. You do have your slide presentations, the pre-test from yesterday, and the Medicare secondary payer form is in the handouts here. So I did get 3 of the handouts to actually work today in there. So pull those off there, and I am getting these slide presentations up on our website at that RHC rural health clinic .com /billing. So it will be there as well. Okay, qualified services to an RHC are considered, and this one here was very tricky. This will get you in trouble. When this first came out in probably 2015 or so, this was a part of Chapter 13. They updated it, and what it said was if the qualified services provided to an RHC patient are considered RHC services if the practitioner is compensated by the RHC and the cost of service is included on the RHC cost report. And the first thing I said, I called up Captain Axelrod and I said, wait a minute, if that's the case, then all we have to do is put this on our cost report and pay them for a service, then we can include that as an RHC visit. And she was like, no, that's not what that really says. I'm like, well, that's what it says. I read it right here. It's what it says. And so she came back and she added a line the next year that says other requirements for furnishing services are met. So that makes sure that sort of protected her from us going out and running a bunch of services as an RHC, because that was a bunch of businesses planned at the time in 2015. So keep that in mind. Is if you're providing RHC services, that compensation has to show up on the cost report. If it's not being billed as a rural health clinic service, that cost has to be pulled out of the cost report. So let your person who's doing your cost report know that. That's going to be very important. Here are the locations for an RHC visit. One in your certified rural health clinic, that's revenue code 0521. The patient's home, if they go to their house, it's a 0522. If you go to the nursing home, if it's a skilled nursing facility that's paid for through Medicare Part A, Medicare patients have 100 lifetime days for skilled care. And if it's a part of those 100 skilled days and the physician shows up, that can be a rural health clinic visit, and that's available under revenue code 024. If you have a nursing home, it's an ICF, or basically once your 100 days are used up, you can bill that, and that feedback is driving me nuts. You can also bill that as a rural health clinic visit as well. That's going to be revenue code 0525. And then if the patient is living in an assisted living facility, that's going to be revenue code 0522.
All right.
The scene of an accident is 0528, which I've never seen that done in 35 years.
Okay.
Telehealth is a 0780 revenue code, and that will be done in the rural health clinic. And then the behavioral health, that's for a mental health provider, that's going to be 0900, and that's revenue code. Okay, so here we have another question.
Okay.
What place of service code should an RHC use when billing services on a UB04? And Danny's got this opened. And let's see here. See how we do. Ooh, this is all over the place here. This is going to be a good one. This is going to be a race. And we're getting, okay. Here we go. Then what place of service code should an RHC use when billing services on a UB04? UB04, that is the key to that. Okay, we've got 60% voted. Everybody giving up on this one? Okay, let's go ahead because it's amazing how fast time gets away on these little sessions here. So close those out, Danny, and give me the answers.
Yep. 40 code serves the place of service code on the UB. And then the next highest was 30%. That said 72.
Okay, and then 11 got 23%. The right answer is C, because on a UB04, you do not put a place of service code. You will use those revenue codes that we just talked to you about. That is your actual place of service. You notice where I said where each one of those was located. You use revenue codes on the UB04. Now, you can use place of service 11 or place of service 72 when you're billing on the 1500 form. And for lab services, what we typically do is we tell, and Louise, I want you can tell me if I'm wrong on this one here, but my usual recommendation is if you're billing the Medicare Part B, your lab services, put place of service 11 on there. They will pay you for that because if you put 72, a lot of times they say, well, that was a part of an institutional provider and that should be a part of your cost, and they'll deny that claim. Now, Louise, what do you guys do for that?
We do 11 on our 1500 forms, and the 72 is used based on our contracts. So in Tennessee, we have one TennCare that wants us to be contracted as a RHC. They require 72. Yeah. The others left us under the professional, even though we are an RHC because we were previously contracted. They want 11.
Okay, so basically you want
based on your contract.
Yeah, follow the contract for that when you're billing your lab work. Do y'all do X-rays at your place, Louise?
We don't.
You don't? Okay. As I have to say, I'm not sure if it would work on billing those technical components with I would think 11. Typically 11 works when you're billing a Medicare. So, and then based on your contract, use 72. Which group, which is it AmeriGroup that requires you to do a 72 in Tennessee?
Correct.
Okay, that's what I thought. Okay, all right, that's very good. So some of that, I think that was helpful to you guys because we had a lot of people there that did not have the correct answer on that one. So that's why we do this. There's just a nice, pretty summary of revenue codes for you guys. And then here are some revenue codes that you would use for your Incident 2 services. Revenue code 0250, pharmacy item with no J code. And then if you do have a J code with that, that's a 0636 is the revenue code for that. The venipuncture, that lone lab service where you draw lab, you're going to use revenue code 0300 for that. And if you're a telemedicine originating site, that's going to be 0780. Louise, on the 0636s and the 0250s, do you have any words of wisdom for us on how to deal with those Incident 2?
We don't do any of the pharmacy codes. The HCPCS we do, and you also have to have the NDC. Now, on a lot of the TennCares and even the commercials now, they're only using the national database with the NDCs. So if it's on like a local but not on the national, a lot of those are kicking some of those out.
Claims are rejected. Okay. All right. Perfect. All right. Let's move on here because time is eating up here. And here are items that aren't paid for on the fee schedule. Your chronic care management was paid at $67.03 last year. This year, that rate has gone down a little bit. I think it's 66.93 or something like that. It's about 10 or 20 cents difference between those. And then your telehealth originating site, remember, an RHC can only be an originating site. It cannot be a distant site. And so right now, RHCs are getting paid $26.15 for that. Use revenue code 0780, and your HCPCS code is going to be a Q3014. Again, I have not seen very many rural health clinics doing telemedicine just because you can only be an originating site. And here's your claim forms. Typically, you're going to use a bill type 0711. This is going to go in form locator. What is that form locator? Number 4, I believe, is 0711. That means you're asking Medicare to pay you money. This will be the one that you will use most of the time. 0710, that's you're sending in that to Medicare to get a denial because it's a service you know Medicare will not pay for, but a lot of times your patients don't believe you, so you have to send it in and get a denial from them. An adjustment claim, a 717, you may have to adjust your charges on a claim if you're billing incident to something occurs within 30 days. You can bill an adjusted claim. That's a bill type 0717. Or you could cancel a claim. Maybe you've already billed it before and you notice that, oh, wait a minute, this is for the same service. So you can bill a 0718 and that will cancel your claim. Louise, you got anything on bill types? Any secrets to that? Is that pretty much what you need to do?
That's what we do now. When you do an adjustment code, you do have to have the ICN or the DCN number.
Yeah, it's called a document control number, because you have to tell Medicare which claim you're adjusting. So there should be like a 9 or 10 digit number somewhere in there. It's called a document control number, and you'll have to put that in there. I think it's in form locator, maybe 64, something like that. But you have to put that. You have to put a condition code typically on there when you do adjustments. We'll talk a little bit about those as we go through this stuff as well. Negative reimbursement. Let's get to our negative reimbursement here. What are we doing? We're at 347 already. This is amazing how fast this goes through. So, okay. Negative reimbursement occurs when the cost of the visit is greater than the provider encounter rate that's billed, and the billed amount is applied to the patient's Medicare deductible. So this is an example from Novitas maybe, or I think it's Novitas. So we billed $115. It's January the 1st, 2020. Our all-inclusive rate was $75. The beneficiary responsibility is $115. And what Medicare says is, well, your rate was 75, 115, you collected 115. So we're going to take away $40 from you. And then this is a big deal now because the Medicare deductible is $198 and the independent RHC cap is $86. And so they could potentially take back $112 from every Medicare claim that you submit this time of year. That's why we recommend holding your Medicare claims until March or April until somebody else gets that deductible. So otherwise, they're going to be taking away $112 from your money. This one's important. This will be hard. This will be a hard one too. So Danny, if you open up the poll, when posting a negative reimbursement claim, an RHC should always A, ensure that the patient balance remains correct after posting, B, post the withhold to the patient balance, C, include the negative reimbursement on the credit balance report. There's that quarterly credit balance report that's out there that you can put in credit balances. And we got, it's going, okay, here we go. Oh, wow, it was, okay, now, okay, and we got 49% of you voted. This is a hard question here, so 55% have voted. Okay, and we're getting more and more. All right, Danny, we're going to run out of time here. Let's go ahead and close it off. That's at a good stopping point. Give me the answers on this one.
Yep, 70% says ensure the patient balance remains correct after posting. 23% include the negative payment on the credit balance report, and 7% post the withhold directing directly to the patient accounts receivable.
Yeah. And A is the correct answer. Ensure that the patient balance remains correct after posting. So in our example above, if our patient had a $115 deductible balance and they had not paid that, whenever you post, make sure that it posts to you that whenever you get, whatever you do when you get finished, is that Mark Lynn still owes you $115. You don't want to change that based upon, okay, well, they withheld $40 from me on Mark Lynn, so now Mark Lynn owes me 115 plus 40, or don't let that money hit the account here. So here's the example of how it works. Whenever you first charge the patient, you're going to have revenue that's generated. You charge Mark Lynn $115, and we have accounts receivable is $115. When we receive our remittance from Medicare, they didn't pay us anything on Mark Lynn's claim. They actually said, we withheld from your other payments that you received on that claim. So you did get some money, maybe you got $1,000, but you should have received, $2,000. And what you want to do is reconcile your bank. Whenever you reconcile your bank account, you're gonna say your bank balance will be negative $40. That's a credit means a negative number, and your Medicare contractual adjustment will be a $40 debit. So you debit 40 to Medicare contractual, you credit your bank balance for the lost money, the negative $40. It will not affect the patient's account whatsoever. So Mark Lynn will still owe you guys $115 when it's over with. That way, everything will be balanced. Louise, is that the way you guys do things, or is there a better way to do that?
No, that's exactly how I do it. Also, the only exception that I find is when Medicare is secondary and they apply more than what the primary left for the patient toward the deductible. So say the patient hadn't met their deductible, but Medicare goes ahead and credits them 110 toward their deductible, but their copay was only 40 or 50. We only bill what the primary said.
Okay.
To the patient.
Okay. So when Medicare is secondary, that becomes an issue there. Okay. Very, very good. That's the sort of thing we need to know. Medicare Advantage plans, we talked about those a little bit yesterday. Once a patient goes into Medicare Advantage plans, it's basically like they have commercial insurance, and you go out and contract with them. And so whatever you contract with them is what you can get paid. I think Louise was telling me about AmeriGroup. Maybe they have a Medicare Advantage plan as well, and they will pay you what the RHC reimbursement rate is here in Tennessee. A lot of times, we always tell people is just get fee for service. You'll actually be better off if you're an independent RHC. If you're provider based, you really want to work those Medicare Advantage plans and try to get them to pay your reimbursement rate. So because it is much better. Qualified visit list. Here's the QVL, and this is our last question here. So I wanted to get through those, and we're on 3:53 here. So we will stop right here, and then we'll pick up tomorrow. And we may have 7 or 8 hours of these sessions for you guys. So you'll get a lot to learn through this by the time it's all over. Okay, Danny's got the poll open here. In order for an E&M code to qualify to be paid at the AIR, the HCPCS code must be found on the QVL. Don't you love the alphabet soup that we have here? The acronyms that we use have an E&M code, AIR, that's the all-inclusive rate. The HCPCS codes are the codes that you bill, like a 99213, and then the QVL stands for the qualified visit list. So we got our answers coming in. In order for an E&M code to qualify to be paid at the AIR, the HCPCS code must be found on the QVL. And okay, we got 54% of you guys voted. Are you still? Some of the people probably had to bail out here. Let's go ahead and close it down. And Danny, what's our results?
66% said true, 34% said false.
And the answer is false. So we tricked you on that one. The reason why the QVL listing is requirement. That went away October the 1st, 2016. So the QVL listing is mainly a suggestion. It's guidelines to go by. But if you have a HCPCS code and you think you deserve the all-inclusive rate for it, bill it to Medicare and see if it'll go through, even if it's not on that qualified, that QVL listing. That QVL listing has not been updated since I think August the 16th, 2016 or so, something like this. Sometime August 2016, the QVL listing has not been updated. So you guys, it's guidelines, hang on to it. It's 11 pages long. You want to look through it, make sure that the E&M code is on there. But if it's not on it, you can go ahead and try to build that to Medicare. It's just a guideline. So I think this is our stopping point here. 3:50. We have 5 minutes left of our time. Danny, do you have some questions here? And then we've got some. Looks like we got some hands up. And we will start tomorrow right here. So let's see here. If you'll find a question, I'll look for the people's hands up to open up a line in a minute.
Yep. The first question is, are procedures such as injections, minor surgery, and sonography covered under the RHC benefit?
The first two are definitely. The last one, what was that last one?
Sonography?
Sonography. I don't, Louise, do you know the answer to that one? Because I don't know that one off the top of my head.
I'm not sure, but that may be one that if they don't have a qualifying E&M code, they can look up that QVL and see if it's one that they could add the CG modifier to perhaps get paid. We do that for like our toenail removals if they're scheduled to come in for that.
Okay. Okay, we will look. I'll do a little bit of research on that too, and that'll be our homework for tomorrow. So whoever had that question, if you don't mind emailing that question to me, and I'll look it up tomorrow when I work on this, because I'm not even sure how to spell it. So it sounds like a technical component to me. That it looks like it's probably one of those services where there's a technical component that you can build a Part B, and there's a professional piece that's going to stay in the RHC. But let me send that to me, and we'll work on that one here. I'm going to open up Elena's. She's got her hand up. Yes, Elena, your line is open. Do you have a question? Hello, Elena, do you have a question? Okay, I'm just going to close hers. Danny, do you have another question from the chat box?
Yep, and Elena actually texted in and said she didn't have a question. Sorry.
Okay, no problem. No problem.
The next question is, can a hospital lease the clinic and be covered under their RHC umbrella?
Can a hospital lease the RHC and be covered under what?
Under the RHC umbrella.
The RHC certification is a site-specific certification. So from the little information I know, that the answer would be no. If you have the RHC is located at, if your RHC is located on 701 Jones Avenue and the hospital is located at 702 Jones Avenue, then that hospital has to go through the RHC certification guidelines or rules, just like it never was an RHC. So I believe the answer is going to be no to that one. Let me, Tina, let's see, Tina, I've opened up your line if you have a question.
Yes, I do. If you say hold our billing till March, my question is, then we're not going to try to collect their amount of money for their deductible. Is that correct? We just don't collect anything for that visit?
No, I mean, I would go ahead and let me let Louise answer that question, because she's got more experience of what you actually do. Louise, what would you do? What do you do in that situation where if you hold your claims until March, do you just not try to collect that deductible in? Because I think Tina makes a good point. If you collect that deductible from that patient and then somebody else eats that deductible, you've got a mess. So
Our rule of thumb here is we don't collect the deductible up front. If they have Medicare and a secondary, especially Medicaid, chances are you're going to get paid by that insurance company for the deductible. So we go ahead and bill those claims. If they have Medicare only, we might hold those.
Okay, so if you have
I
Medicare,
do
go
understand. I'm
ahead.
just talking about Medicare only.
Yeah, and so for Medicare only, I think what Louise said was, yes, you would definitely want to hold those claims and not try to bill that to the patient because.
Okay, and not collect. Okay, thank you.
No problem. Thank you. Okay, let's see. Okay, do we have any other? Danny, do you have any questions in the chat?
Yep, I've got 3 more.
Okay.
One of them is there a visit requirement for licensed clinical social workers?
Is there, I think what she's talking about is productivity standards, and there is not. There's, for a physician, the productivity standard is 4,200 visits for a full-time physician working 40 hours a week, 52 weeks a year. It's 4,200 for nurse practitioners and PAs. It's 2,100 visits, and then your clinical social worker will drop down below the line, and there's no minimum productivity on those. If that was the question. Okay, I'm going to open up the line for Bridget. Bridget, your line is open if you have a question. Bridget, do you have a question? And I don't know, Bridget. Okay, Bridget, I closed your line. You can hit us in the chat box if you see it and want it opened up. Danny, you got another one?
Yep, Pamela Eubank says, would AmeriGroup be required to credential as provider-based? They have credentialed us with the independent cap.
Okay, well, read that question one more time.
Oh, I lost it. Would AmeriGroup be required to credential as provider-based? They have credentialed us with the independent cap.
Let's see. I don't know how to answer that question. It isn't. Send me that question because it depends on what state you're in and how. I mean, because what happens is AmeriGroup is going to be paying Medicaid. They're not going to be paying Medicare, and that's a Medicaid question. So send me that question via email, and I'll take a look at it depending on what state you're in.
Margaret said she's in Tennessee.
She's in Tennessee.
Mark,
Yeah. Tennessee's not going to pay the rate anyway. Louise, you got to. In Tennessee, they're not going to pay the RHC rate. The way you get your money in Tennessee is you do a quarterly RAP report to the state. They're going to pay, all your MCOs in Tennessee are going to pay you fee for service. And then every quarter, and Danny does these great. So we'll do a little advertisement for Danny who works for us. There's a TennCare quarterly report you have to submit, and they will pay the difference between those rates. And Medicaid and TennCare will set your rate for you. And so it's really not whether you're provider based or independent in Tennessee, because there's no difference in the rates that they set. They don't make a differentiation between that. Louise, you got something to chime in on that?
with AmeriGroup, what we are an independent based RHC. They had us contract as an RHC. So our individual doctors are not independently contracted. We put them on the roster of the RHC. Mm-hmm. If that's what she's asking.
And I will say she just typed in and said she's talking about a Medicare Advantage plan, not Medicaid.
Oh, Medicaid. Yeah, I mean, Medicare Advantage plan is you have to, whatever you have to contract with them, whatever the contract says is what you get paid. They're like a commercial insurance company is what they are. So.
And they are the only Medicare Advantage plan that we have run into that made us contract under RHC.
And so they pay your rate, but they're not paying. What I would do is I would send them your rate letter from Medicare. So if you're provider based and your rate is $125 a visit or $207 a visit or whatever that number is, send that to them and say, hey, you want us to be an RHC? Our rate's $207 a visit. You need to be paying us $207 a visit, not $86.31. That's what I would do.
That is correct, because I send them the Medicare rate letter every year to make them adjust theirs.
Yeah, so that's what I would do. Okay, you got another one?
Got a couple more. Regarding the telehealth visit and the originating site, is the doctor at the RHC clinic or the patient?
The patient is at the clinic, at the RHC, and the doctor will be at the distant site. So in our case here, they show up at Louise's clinic, and he's over in West Tennessee, and they see a cardiologist in Nashville. That cardiologist in Nashville is going to get his fee for service for providing his full fee for service for doing his cardiology, and we're going to get $26.19 or whatever that number is for providing that service in West Tennessee. Does that answer your question? One of the things is you have to make sure you have a provider on site too, because anytime you do any type of medical services, you're going to have a nurse practitioner, physician, PA physically on site. So you would have to have a provider on site. They may not necessarily be doing services for that patient, but they have to physically be there. Louise, does that sound right? Okay.
Yes, that does sound right.
Okay, perfect. Okay, and next question.
Yep, one more. Should you bill incident to services or not? I was confused when you were talking about it. We currently do not bill. Just making sure I understood you correctly.
You should bill incident to services because you're going to increase your copays and deductibles. You ain't gonna get paid any more money from Medicare. If your rate is $69.05 as an independent RHC, or if your rate's $166 as a provider-based RHC, your payment will be exactly the same no matter what you charge. But when you cross it over to the Medicare secondary, or when it goes to the patient's bill, if you're charging for that 96372 for administering a shot and that J code for your Rocephin, that's going to increase your charges, and you're going to get 20% of that. So you should be billing incident to. You don't have to bill that. Some of the services, venipuncture is a big problem. So I come in and they want to check my blood for whatever it is, and they want me to be fasting. So I'll come in on Friday morning, and you charge $10 for that venipuncture. That's an incident to service, but it's almost not worth the trouble to put that with the office visit that occurred a week earlier. Is that, Louise, is that sort of what you guys, how do y'all handle that when you're on your venipunctures? Do y'all bundle, bundle them?
Well, we actually have a phlebotomist from a lab company that does ours, so we don't worry with the venipunctures. The incident too, that what we do is, like, if they're here in the office, they do get injections or a procedure done the same day. Be sure you add all your totals up and put it on that CG HCPCS line, or you won't get additional money from copayment. All the total has to go on that CG modified line to get that extra payment. We do have a few that come in like every week to get an injection, but then if they're here in that 30-day window, I hold those claims and then I add them to that 30-day visit.
Okay, that's perfect. That is perfect. Okay. Danny, do we have any more? I don't see any hands up. So
it looks like Elena was going back to one of the earlier questions. She says, why would the deductible not be collected up front for Medicare only? When you're talking about the holding the claims and not collecting the deductible, I think that's what her question is referring to.
Yeah, and Louise, you can correct me if I'm wrong, but what will happen is if you hold that claim and you're holding a claim, you're not going to bill it until March the 1st, and you're hoping that a specialist, the cardiologist we talked about, is going to see that patient, and their claim will eat that deductible. And if you went ahead on January the 1st and collected that $198 from that patient, and then the cardiologist is going to send a bill for the $198 as well, because in the Medicare system, they should be collecting it. So you're actually, if you collected that $198, you would end up getting overpaid, and you'd have to refund that money back to the patient. That's why you want to hold. That's why you don't want to collect that money if it's a Medicare only. Is that right, Louise? Is that the right situation? Is that the right way to explain it?
Yes, if the clinic's policy is to collect the deductible based on the eligibility check for that date, just keep in mind that it still may have some claims already in processing that hasn't reported against it. That's why we don't collect deductible up front. But if your policy is to collect deductible up front, don't hold the claim, go ahead and file it. If you didn't collect the deductible, then you can hold it hoping somebody else gets it.
Yeah. Okay. Okay. Danny, do you have any more questions for us?
No, sir, that's it.
All right. Well, that was very good. Thank you guys for attending today. Like I said, we've added another session. As slow as we're going on this thing, we may be here until March to be filing our Medicare claims at this rate. So here's where we'll stop right here for today. We'll have some more questions for you guys tomorrow, and we'll just work our way through this. Louise, if hopefully you can be here with us again tomorrow as well, because you're doing great. And then we'll have twice as much help tomorrow because Cammie will be here to help us as well. So thank y'all, everybody, for attending. We appreciate it very much. We will see you again tomorrow, it looks like. Thank you. Thank you, Louise. Thank you, Danny.
Thank you.